Hey, medical class. I wanted to introduce Krista Treichel to you. And Krista, thank you so much for taking time to talk to our kids today. And this coming year, when we are back in school, I hope to have you come and speak live and in person.
That would be great. I'd be happy to. Thanks for inviting me.
Absolutely.
All right, I'll get started. So I am here to talk about a career in nursing, and I am an oncology nurse, so I'm going to focus on that. But a lot of what I talk about is going to be applicable to lots of different areas in nursing. So why did I choose nursing? Well, one thing, when I was deciding, I actually had a degree in biology already and was working in a lab, and I wanted to be working with patients and people instead of just blood samples and that sort of thing. So I was working initially in a lab and then eventually got into law enforcement when I was here in Colorado. And when I was doing law enforcement, decided that this was not for me. So decided to go to nursing school. So I didn't even do that until I was in my 30s. So I have been a nurse now for 18 years. And I've been at the University of Colorado for all of that time. I was in the oncology unit in the hospital at the original University of Colorado Hospital campus at 9th Avenue downtown in Denver. And I'm now in the melanoma clinic that's on the Anschutz campus. And it sounds like some of you have probably been out here before. So let me flip back here. Sorry, my screen just flipped. Here we go. So I have been an oncology nurse my whole nursing career, and I've been in the melanoma clinic for the past 14 and a half years. So a lot of what I'm going to talk about is related to my work in the melanoma clinic. And again, back to this slide, why did I choose nursing? Well, because you can really do anything with a nursing degree. You can travel, you can do all kinds of, whether it's administrative or actually clinic and bedside nursing, research. There are lots of different fields that you can work in nursing. I primarily got into it originally because I wanted to travel and be a traveling nurse. And I thought that I was still relatively young in my early 30s. And so I thought I would be traveling around the country and just take nursing gigs wherever I could find them in different states, or I could go to Alaska for 3 months. Usually the stints are 3 months. And I never did travel. I ended up just really enjoying my job here, and I stayed here and moved around from the hospital nursing to the outpatient clinic nursing, and I've loved it, and I haven't left. So that's why I'm still here. So on my slide here, as a nurse, you get to work with amazing, dedicated, super smart team members. It's a very collegial kind of atmosphere, very collaborative. So I think a lot of people have this image of nursing as you're kind of the assistant to the doctor, and that's really not reality. The reality is we're equals, and a lot of times the docs will sit next to me and say, hey, I want to do this for that patient. What do you think? Did you have other ideas? So it's very collaborative. I work with pharmacists, I work with medical assistants, I work with administrators. So you really get to work with some amazing people. And that's the reason that I'm still in nursing, because it's tough, it's not easy, and it can be exhausting mentally, physically, but you have your team that backs you up 100% and gets you through the day. So I think that's the best part about the nursing right now that I really like. Job security, no matter where you go, you will find a job. And that's a really nice benefit. So if for some reason you have to move suddenly, you weren't planning to, you will always have a job. And as I said, you can travel. So traveling nurses, they go to Hawaii, Alaska, all kinds of places all over the country. You can work in lots of different types of nursing when you're traveling as well. You don't have to get stuck in one particular type of nursing. So it allows you to just travel wherever you want to go. As I said, there's a variety of areas to specialize in. So you can do in the hospital or inpatient nursing, which is we call bedside nursing, but you can also do outpatient and work in some of the outpatient clinics. You can work in private practice. If you're into dermatology and skin, which is kind of mostly of what I do, you can work in dermatology offices. You can work in some of the Medi-Spa offices that are doing Botox injections and that sort of thing. Or you can get very specialized and work with cancer patients like I'm working with. You can be a nurse educator. Those are nurses that teach, and I happen to do a lot of teaching in my role. And so I'm not officially a nurse educator, but it's still one of the things that I really love about nursing is that I can educate other nurses, I can educate you guys, I can educate other places out in the public. I go to lots of different places to do education. So it gives you a lot of variety. You can be an administrator. So if you're interested in kind of behind the scenes, marketing, the budgets and that sort of thing, there's lots of roles for nurses in that area as well. Actually, I think that's really growing because it's been an underrepresented area in hospital administration. And so now they're just starting to realize that nurses have a lot to offer and insight that maybe just like a business person doesn't have. And so they've been including nurses a lot more in the administrator roles. You could work for pharmaceutical companies, other medical companies, healthcare companies, and you can do research. There's tons of research that's out there happening in healthcare. And you could be a nurse that specializes in research, which is very different than what we do in the clinics and in the hospital. There's a lot of regulatory stuff around research. And so those nurses are trained specifically to do that kind of work and work with those patients. I'm sure you've heard that nurses are respected and trusted, and they are, according to the Gallup poll, which they've done for a number of years now, it's the most ethical and honest profession. So nurses have a good amount of respect. And when you meet with your patients and talk with them and their families, they listen to you. They care about what you have to say. And they do pay attention to what you say. So what you say is very important, and you need to be correct in the way you're saying things and what the information you're providing to your patients. So they trust you. It does take some time to build that trust, 100%. But once you have it, number one, you're going to be the person that they go to, which is something that I really love about this job. And then advancing your career with education and professional development. So you could go back to school. Most RNs have a BSN, which is a Bachelor of Science in Nursing. That's the degree that most of us have in Colorado. Not every state is requiring that. Some are still allowing associate degrees for nursing. And we do still have some around here in Colorado. But for the most part, we have bachelor's degrees. But you can go back and get your master's in nursing. You can be a doctorate of nursing, so you can do that as well. And then they have some specialized kinds of degrees that are clinical nurse coordinators, nurse practitioners. You can go for public health, which obviously now in COVID, that's a huge field and it's going to be growing significantly. So public health nurses are going to be in high demand very, very soon. And of course, I mean, the thing that you hear all the time is you get to help people. And so that does make a very big difference in your patients' lives and the families' lives as well. I'm in cancer and oncology. And so obviously those patients are extremely stressed, anxious. Every day they come in with lots and lots of questions. And so they really do turn to you to help them. And I just see my role more as being an advocate for the patient and letting them make the decisions that they need to make, but advocating for them where they're having some trouble with the system, can be very complicated, or providing education if they need to kind of understand something a little bit more. That's your role as well. So lots and lots of different things that you can do as a nurse. I have pictures here of my group that I work with and that I love very much. And some of these people, so Dr. Ryoth is here. Let's see if I can get a pointer going here. So this is Dr. Ryoth. He just left our practice. So he was our ocular melanoma specialist. I'm going to talk about that a little bit here in a few slides. But he just left to go to, he's going to be actually working not with patients, but behind the scenes. So he left us to work on more of a melanoma computer program. So he just left, and that was his going away day. We go to a lot of different events, and this was a polo tournament that we went to that supported the Colorado Melanoma Foundation. So we participated in that. This is just a group photo we did. That's me at work, and this is some of my other doctors, pharmacists, nurse practitioner, nurse in the clinic. So this is some of my team and where our space that we work in. We have a lot of fun as a team. So, and that's the one thing that we do see in this clinic in particular, and lots of the other specialty clinics, is you're with these people all day. And so you really do build great relationships with them. They're all friends. So that's a big plus, that it's a professional relationship and you trust each other that way, but you also have friendships as well, which is great. So since I'm a melanoma nurse, I am going to do a little presentation here and do some education with you guys so you can kind of see, number one, this is what I do. I do a lot of education around melanoma, and so you get to learn a little something about melanoma as well. I'll warn you ahead of time. I talked to Mr. Stirrup already, but there's some pretty gross pictures in here. It sounds like maybe not as gross as you're used to, but I kind of tamed it a little bit, but there'll be some pretty tough pictures to look at. But I want you to understand melanoma and some of the other skin cancers that are out there. And the pictures kind of tell the story. So just to be real basic, and you probably already know this, some of this information, but what is cancer? So cancer is when normal cells in the body start to grow and divide in a very unorganized fashion. So normally cells grow, divide, have a life, and then they have a kind of a programmed endpoint, a death. With cancer cells, that mechanism, that process is turned off or broken. And so what happens is the cells start to grow and divide out of control. That's where you get tumors that grow. And then they also have the potential to travel through the body, and they can just kind of deposit in different places in the body and grow and divide there. And that's when you cause problems, and that's called metastases. And why does that matter in melanoma? So melanoma is cancer that starts in the melanocytes of the body. The melanocytes are a skin cell, and they're those cells in the skin that produce pigment. Pigment is what the body produces in response to UV radiation. So if you get a tan, that is melanin, that's that pigment that is produced by melanocytes. And the purpose of melanin or a tan is to say, hey, there's a lot of radiation happening here that's not supposed to be, and I need to protect the cells. And so that's what a tan is. It's a response to this radiation exposure. And so what happens in melanoma is there can be lots of mutations, and that's caused by the radiation exposure as well. Most often what you see melanoma start in is a mole, but it can really happen anywhere in the body it wants to, because those melanocytes, again, those melanin producing cells they're everywhere in your body. And so that means under your fingernails, under your toenails, the palms of your hands, and the soles of the feet. It can be on the skin, of course, that's the most common. It can be in your mouth, in the eye, in the ears. So anywhere there are melanocytes, it's not always related to sun exposure, you can develop melanoma. And this picture on the bottom here just shows you the layers of the skin, and then those melanocytes that can produce melanin to protect the skin. So why worry about melanoma? Well, skin cancer in general, that's a lot of different types of cancer, not just melanoma, is the most common type of cancer in the world. So skin cancer is most common. Most of those will be squamous cell cancers or basal cell cancers, which are relatively benign. They don't usually cause a lot of problems for people because you just cut those out and get rid of them, and that's it. Melanoma is a problem, and it accounts for about 1% of all of those skin cancers. So it's a very small percentage, but it is the most deadly because it has the ability to break free from the skin or wherever it started in the body, travel through the blood vessels or the lymphatic system, and deposit in other places in the body and grow and divide and eventually cause problems. So if it grows, it likes to go to places like the brain, the liver, the lungs. Those are the most common places for melanoma to go and become a problem for patients, but it can go anywhere it wants to. So bones, it can go to other places in the skin, which I'll show you some of that. It can go to any organ it wants to. And so that's why melanoma is so dangerous, that it can metastasize, and that's what kills people. One person dies from melanoma every 62 minutes, and there's definitely an increased incidence of melanoma over time now. I'll go over that a little bit more here coming in some more slides. So here's the first slide of pictures, and these are 3 different types of skin cancer. The first one here is squamous cell cancer, and that is a gentleman's face. He came in, he happens to be somebody that works outside a lot and has had a lot of sun exposure over his life, and primarily on his head, on his scalp and facial area. This is one of those types of skin cancers that if you catch it early and cut it out, then you don't see things like this. It's usually just cured. But he let this go for a long time, and so it he came in looking like this. Now, I will tell you that this gentleman is a lovely man, and he did receive some treatment for this. We had to give him IV medication, which I'll kind of touch on a little bit at the end. And you would never know that he had this on his face. He has completely resolved these tumors. So he responded very well to the treatment, which we were really excited about. This gentleman in the middle here, this is actually not the worst of his pictures. This is it kind of healing up a little bit. So most of this is scar, but this is a basal cell cancer. And this is also related to sun exposure. And again, these are usually caught when they're very small and you can remove them and they're cured. But many of these, what we call locally advanced basal cell cancers, this is what they come in looking like, and we do have treatments for them as well. And he's actually in this picture, like I said, this is scar, so this is all healing up because of his treatment. So he's responding very well to that. Obviously still has a long way to go. This is a melanoma. This happens to be one on a gentleman's heel. And you can see that it's very ulcerated. There's a lot of erythema around that wound. This is an extremely painful wound. And this patient had to be admitted to the hospital because he was having so much pain. So we did have to admit him for that, pain control. But he originally had a spot on his foot that was removed. It healed up very well. And then he had a local recurrence, and that's what this is. So the melanoma grew back, and now we're having to treat him for this. So these are the three major skin cancer types that we deal with in this clinic. Melanoma is really going to be 99% of our practice. So I'm going to focus mostly on that, but we'll talk about some of the other stuff too. So just to show you the trends in the incident rate. So over time, you have time zero, or this is at 1975 to 2016. And you have two lines here. You have the female and the male population. And we're looking at trends since 75 to 2016 per 100,000 people. And you can see steadily over time that male and female, the incidence of melanoma is going up and up and up. And we're going to talk about some of the reasons why that is. Now, looking at the 2020 statistics specifically, nationally, about 100,000 people will be diagnosed with melanoma. About almost 7,000 people will die. That's actually a slight improvement from last year. And part of that is some of the treatments that were approved recently have made a big difference in survival for patients. So that's very exciting. We do a lot of research on melanoma here in our clinic and working with melanoma patients. And so it's very exciting to see a lot of the experimental treatments that are coming out are beneficial and have great outcomes for patients. Obviously not everybody, but if we're seeing this is the first time we've seen a tick down in the number of deaths in melanoma. That's a very, very exciting time. In Colorado alone, we have about 11,000 people diagnosed with melanoma, and about 600 people will die in 2020 from melanoma. So why do they get melanoma? Well, this is the primary reason. People are not protecting their skin from sun, and so they end up with very severe sunburns. If you get sunburns before the age of 20, that could be a potential and very likely cause of melanoma down the road. Now, that doesn't mean that anyone that gets a sunburn before the age of 20 will get melanoma, but you increase your risk of getting melanoma down the road if you have sunburns, especially these blistering sunburns, before the age of 20. So be very, very careful. Now, the other thing I'm going to point out, I put in the picture of the ear here, your feet. You just don't cover, maybe your face is very commonly, you apply the sunscreen. Don't forget your ears, don't forget your lips. That's very important, especially when people are skiing in the mountains. You forget that, and so you end up with a sunburn on your lips too. We've seen lip melanomas before and other skin cancers. It's actually relatively common. The tops of your feet, the hands as well. So not just the obvious body parts you want to cover with sunscreen, you want to get all those little spots as well. And of course, the reason that we're seeing an increase in melanoma lately is because in the early 1900s, this is how people lived outside. They covered up. They went to the beach. This is what they wore. Obviously, that's not what we're doing now. So you go to the beach now and everybody's half naked and trying to get as much sun as they possibly can. And I get it because I've been there. I'm old enough to know of the days when we just put oil all over our bodies and tried to, and laid on the roofs of buildings to try to get as much sun as we could and get a really good tan. But that's obviously not healthy. Speaking of tanning, so there's a lot of tanning booths now. People have them in their homes. And so this is a big reason why you're seeing that spike in that curve that I showed you earlier, because the exposure that these people were having when they were younger and not really paying attention, now it's catching up with them. And so we're seeing those spikes in the curve. So just to focus on tanning and be on a little soapbox for a little bit, tanning is not good. The tanning booth and those tanning salons, that industry makes about $4 to $5 billion a year. It's a big business, obviously. The radiation that is emitted during a tanning session is a proven carcinogen. In 2009, the World Health Organization officially reported and released that tanning is a carcinogen. And what that means is, if you think about, we all know this, lung cancer can be caused by smoking. So smoking can cause lung cancer. Well, tanning and tanning booths can cause melanoma. It's exactly the same kind of analysis or comparison. So tanning absolutely is a carcinogen, and you need to be aware of that. The American Academy of Dermatologists says there is no safe way to tan. If you're tanning, it's because your body is telling you that you're getting too much exposure to radiation, to harmful UV radiation. That's why you get a tan. It feels really good, but in the long run, it does not do good things for you. And just a little bit more on that. So one blistering sunburn can double your chances of developing melanoma later in life. Double your chances. Using tanning beds before the age of 30 increases your risk of developing melanoma by 75%. That's huge, 75%. Occasional use, I know some of us, I mean, when I was younger, I remember people saying, oh, for prom, we're gonna go and get a tan, or before they go on vacation, they'll get a base tan. Well, that triples your chances of getting melanoma, just those occasional tanning uses. So be very cautious of that. It is session dependent, the number of hours and years, very dependent on that as well. And then melanoma is one of the most common forms of cancer in young adults, 25 to 29. We have patients in our clinic that we actually had an infant, a baby. Now, obviously, that's not going to be related to sun exposure because babies don't have enough time to have that sun exposure. That's probably more related to genetics. But, you know, teenagers that have probably been out playing soccer that most of their lives and maybe not covering up as much as they should. Those are some people that we're seeing in our clinics as well. So you got to be real careful. And just to give you an idea, there are very few tanning bed laws across the country. And if you just kind of focus on Colorado, they do have some limitations as to who can use tanning beds, but there's no outright banning for tanning beds for younger people. And so that's something that we're very passionate about here, trying to get some legislation through that will allow the limitation or basically eliminating the ability of anyone under 18 to be using tanning beds. That really is the skin and the time of your life that will very much impact if you develop melanoma down the road. So if we can kind of try to minimize that, we will definitely do the work to do that. So just to show you that UV radiation does a couple things. So you hear about UVA rays and UVB rays. UVA rays are responsible for aging, A for aging. UVB rays are responsible for burning. So again, UVB, burning. That's how you can remember. And I'm telling you all about skin exposure to sun and radiation and the chances of developing cancer. But you also need to worry about aging as well. So this will be something that causes a lot of wrinkles and skin issues and spots and that sort of thing. Maybe you have parents and grandparents that are starting to really show the effect of some of the sun exposure they've had in their younger years, and they develop a lot of spots. And so keep that in mind as well. If wrinkles and things like that are something that you would be worried about, if you don't want to be, getting a bunch of Botox injections and that sort of thing, fillers, when you're my age, try to protect your skin now while you can, as best you can. And this really kind of shows you perfectly what I mean by that. So Sean Penn, when he was younger, beautiful skin, no wrinkles. Now, lots and lots of wrinkles. Now, he's a smoker. That's going to do a lot of damage as well. But he spends a lot of unprotected time out in the sun, and that definitely shows. This is a picture. These are pictures taken with a UV camera, so you can see the damage that is not appearing to your naked eye. This is me and my skin damage from over the years. I did a lot of tanning when I was younger. Another person, you can see all these little spots just with the naked eye. You can't see those things, but the UV camera really catches a lot of them. These are some of those sunspots that you develop later in age as well, maybe in your 40s and 50s. These are called solar elastosis, and they are sunspots basically, but this is from exposure to the sun. This is somebody, I don't know if you guys are familiar, she was called the tanorexic. So this is when she was addicted, and it was an addiction to tanning. And this is her now, once she got some help. And there is definitely some kind of a mental health connection and addiction issue with some tanning. And she was able to make a big turnaround. So that's great. Although she's going to show the effects of that when she gets a little bit older too. And I thought this one was interesting because this is a man that's a trucker. He drives in a truck all the time. He's exposed to the sun all the time. And if you draw a line right down the middle of his face, this is the side that is exposed to the window in the truck and therefore getting a lot of the direct sunlight. And this is the side that is not. And so I think you can really visualize here the difference in the wrinkles and the condition of the skin is much smoother on this side compared to this side. This is the effect of those UVA radiation rays that I was talking about. And this is just a cute puppy. So other risk factors. So like I said, sun exposure, #1, no doubt about it. But there are other reasons people develop melanoma. You can have a weakened immune system due to some kind of medical condition. If you have fair skin, so light skin, light eyes, light hair, or red hair, those would be a phenotype is what we call it. That would be higher risk of exposure because they don't have the production of the melanin like most people do when you have that lighter phenotype. A skin cancer history, so if you've already had skin cancers or melanoma in the past, that means that you've already got that genetic sun exposure, whatever it is, that level of risk established. And so you potentially could develop more in the future. And then genetics, like I said, so a lot of those younger patients that didn't have time to get the sun exposure, there's definitely a genetic component with melanoma. It's certainly not strictly sun, but the sun is something that we can control. Genetics, you can't always control. This is another issue around developing melanoma. So this is called dysplastic nevus syndrome. And basically what that means is you have many, many moles. And we're talking 50, 100 or more moles all over your body. And you may know people that are like this. And when you look at those moles, so you can see here, they all look a little weird. They look a little irregular. So the potential of any of these being abnormal is very, very high and actually probably 100% likely. But there's also the chance that you could develop melanoma in those spots too. So these are people that go to the dermatologist a lot and have their skin watched very closely. And just to go by race, so melanoma is not anything that is only for white people. This affects every race around the world. And so looking at per 100,000 people in the African-American group, 1 person could get melanoma. That's the incident rate. In Asian Pacific, 1.6, Hispanics, 4.9, Indian, Alaskan natives, 7, and then non-Hispanic white, 37. So obviously the lighter skin group, the white group is a higher incidence, but that does not mean that it's the only group that has an incidence. Every race needs to protect their skin from the sun. So how do we diagnose melanoma? And early diagnosis is critical. There's no blood test. So some of the other cancers out there, you can just have a tube of blood drawn and they can measure what we call markers in the blood. And that will tell you if you have other cancers, but melanoma doesn't have that. So unfortunately, we don't have an easy way to diagnose it. early identification and treatment is the best way to do it. And so what we do is we teach people the ABCDEs. I'll get into that a little bit more, but really what that's looking at is the characteristics of the spots on your skin. And if you have some spots that are suspicious, you go get a biopsy, go see your dermatologist or even your primary care doctor. They can do the biopsy for you. That specimen is sent to pathology. They're the microscope guys. They will look under the microscope and tell you if it's melanoma. And one of the things that they look at specifically is the depth. And so this is a demonstration of looking at the depth. It's called Breslow's depth because Dr. Breslow named it. There you go. The pathologist will basically, what they do is they put a ruler right next to the slide. They cut that tumor up into very, very thin slices. They mount it on a slide and then they look at it, and with the ruler they measure. This is the top of the skin. This is the fatty layer and muscle, very deep sections of the skin. How deep does this melanoma go into the skin? They measure that in millimeters. And so anything that is basically 0.75 or less is considered a thin melanoma. 0.75 to 4 is an intermediate thickness melanoma, and anything deeper than 4 millimeters is considered thick. And those are very, very high risk. And you can kind of see here's some blood vessels in the skin. And so the deeper the melanoma goes into the skin, the more likely it has access to those blood vessels or lymphatic vessels. And then those cells can break free, travel through the vessels, and then travel through the rest of the body and cause problems. So the deeper ones are very, very high risk. Let's skip that part. So this slide is a survival curve. And what this is showing you is at time 0, everybody diagnosed with melanoma is alive. And over time, that obviously changes because you can see those curves kind of dip down. This is all dependent on the thickness of the melanoma itself. So the top line, these are patients that say 10 years, over 90% of those patients are still alive, as you can see here. Compared to the greater than 4 millimeter curve here, at 10 years, maybe 40% of the patients are alive. So you can see that the thickness of the melanoma makes a huge difference in survival, long-term survival, out to 20 years here we're looking at for these patients. So the thickness, the earlier you catch it, the thinner it is in the skin, the better. So we'll start looking at the different growth patterns of the melanomas. And there are a few different types. Cutaneous melanoma is the most common, that's on the skin. And there are a number of different kinds of cutaneous melanoma. So superficial spreading, nodular, acral, lentiginous is on the palms of the hands and the soles of the feet. Subungual is under the nails, so the fingernails and the toenails. Lentigo maligna are very thin, but can be kind of scary and ugly. And then desmoplastics have their own characteristics as well. And those are mostly identified by looking at them underneath the microscope. You can see the differences. Mucosal melanomas, these happen in mucosal membranes. On the kind of the mouth has a mucosal membrane, then the nasal cavity, your throat as well. And speaking of that, I'm going to take a little sip. As well, and again, these are areas that don't have sun exposure typically, so but they do have melanocytes that can break, and so those are probably more related to genetic types of issues. Vaginal area as well, vulvovaginal, and then anorectal as well. Those are mucosal surfaces. And then ocular melanoma, so there are a number of places in the eye, different places in the eye that can develop melanoma as well. So into some pictures so you can kind of see what these look like. So this is your most common, superficial spreading malignant melanoma. This is just on the skin. You can see it very, very irregular looking. Maybe there's some different colors in here as well. So that's a very typical melanoma. Again, a superficial spreading malignant melanoma. This one I think is real interesting because you can see this super dark area and then this very faint kind of lighter area. This is something we call regression. And so this is concerning because if there is this regression area, it means that this at one point was covering the whole area, but the immune system noticed it and said, hey, this is not normal. And so it started to attack it. And so you see kind of this faded, shadowy area of where the melanoma was. So that tells us if we see regression like this, this was a much bigger lesion at one point. We're just not seeing the entire lesion right now. This looks nodular. This looks like there's a nodular melanoma here. And this is another one. Again, kind of those really different looking areas, bumpiness, those are things that we look for. This is a nodular melanoma as well. Kind of self-explanatory, forms a nodule on the skin. This is going to be a very extreme nodular melanoma. This is obviously somebody's bottom and their back. And this is going to be resected in the OR. And so here's another view of that. This is not a person that did very well. This was they probably have widespread metastatic disease by looking at this. Again, there's a very small nodular melanoma here. And then this is an example of those subungual, so underneath the fingernails, and then the acral lentiginous, which is on the soles of the feet or on the palms of the hands. And if you, I don't know if you guys would recognize this guy, you're probably a little young. This is a reggae musician. He's very famous, Bob Marley, and he died back in 1981. And I don't think a lot of people know that he died from melanoma. He developed acral lentiginous melanoma, and he played a lot of soccer. And so he thought he just injured his foot during soccer, and he didn't really think much of it. But unfortunately, he ended up with metastatic disease and died very quickly from metastatic melanoma. So, you know, just a perfect example. Anything out of the ordinary, anything you're not really sure, anything that doesn't go away in a few days, like an injury normally would start to resolve in a few days, you need to have that looked at. This is lentigo malignant melanoma. These are seen very frequently on older people, and these are sun-exposed areas. This looks really, really bad, and usually these are very, very thin. And so once you excise that area, you get a nice clear border around them and just excise that out of there, they're usually cured. They don't usually metastasize because they're very, very thin, although they look really, really scary. And they can get worse. So if you ignore them, they definitely could get worse over time. And this is your melanoma mucosal in the mouth. So you can see this young lady has a very large hole in the roof of her mouth where the melanoma, the cancer cells ate through the roof of her mouth. And here you can just see some very dark pigmented areas. These are very difficult to treat, unfortunately. And then here's a couple of pictures of the eye with melanoma in the eye. And those actually are not super related to sun exposure. So those have a very different kind of mechanism around them. Head and neck melanomas. So here's a few more pictures here. Definitely be looking in your hair and look at your scalp to make sure that you don't have any worrisome spots. Good idea to be doing some, if you go to the hair salon, ask them to take a look, or have your parents or friends take a look at your scalp. Really good idea to be looking there frequently. That's one that we miss a lot because you can't see it yourself. And so you can't recognize that there's a problem going on there. And then a few more here. So on the foot, on the forearm, this is not a person holding the tumor, but this is actually the tumor growing out of their hand. This is under their armpit. So this is their arm and their back. And this is a very large melanoma mass. We took care of this patient in the hospital, and remarkably, this shrunk and he did very, very well with his treatment. So as scary as some of these look, there's still some treatments that work and can make a big difference for people. Here's one on the lower leg, lots of different nodules there. And this is really just a joke more than anything. So this is a great white shark, and there's pigment in there. So even animals can get melanoma. I don't know if that is melanoma, but they certainly can. Dogs get it pretty frequently, and most commonly it's the paws or around their nose. So if you have dogs at home, check their feet. This is something called in-transit melanoma. So what happens is, so this is a leg, excuse me, a leg, and probably the melanoma was on their foot or ankle, the lower leg somewhere. Excuse me. And when, sorry, too much talking. When the melanoma was in the skin, it had the opportunity to break free from the skin, travel in probably blood vessels, and then get trapped in the skin. And so what happens is, over time, you don't always know this up front, But those cells get trapped in there, and then over time, for whatever reason, whether it's something with the immune system that turns off and allows them to grow, we don't really know the answer. But they get trapped in the blood vessels or lymphatic vessels, and then eventually they get turned on and they start to grow and divide. And so then you start to see all these little black spots show up on the skin surface. It's usually on limbs, so arms and legs that we see this. I think this is a leg here, but this looks like somebody's chest area and shoulder. And so we can certainly see it anywhere in the body. Most commonly, we'll see it in the limbs. Here's another picture of that. So here's the thigh on a patient, and you can see all this melanoma got trapped in those cells and was growing and dividing, and eventually did cause problems for this patient. And there are definitely things we can do for this, so it's not hopeless, but this is not a great situation to be in as a patient. So for staging of melanoma, we look at a number of things. For stage 1, those are melanomas that are thin, so less than 1 millimeter, 0.75 millimeters. Those generally are just treated with excision. So you take a wide area of tissue around that melanoma, usually about a centimeter around, and you remove it. And then those are usually, I wouldn't say cured, but that's the treatment for that melanoma. So those are stage 1. They stay in the skin, usually don't cause any problems. Stage 2 are the thick melanomas, and those are greater than 1 millimeter. And again, those are treated just with excision, but those patients are at higher risk of recurrence, and so we usually see them more frequently. The stage 1s, usually they'll just follow with their dermatologist and have regular skin checks. The stage 2, we usually do continue to see them in our clinics and follow them closely because they're higher risk of developing metastatic melanoma. Stage 3 is when it's in the lymph nodes, and usually that is the regional lymph nodes. So for example, you have a melanoma on the hand, and the lymph nodes usually are from the armpit, and if there's melanoma there, that would be a stage 3. So you wouldn't call a melanoma that started on the hand and you have lymph nodes, say, in your groin. That would be a distant, not local, is what we call it. So stage 3 is a local involvement of the lymph nodes. And then stage 4 is distant organs, or it can be lymph nodes as well that are involved with melanoma. Those, both stage 3 and stage 4, are going to be treated with systemic treatment. So we have to give them some kind of treatment to help them. Otherwise, their disease is going to continue to grow and cause problems and eventually kill them. And so how do you treat cancer? This may be very basic. You probably already know this. So radiation is one type of treatment that is more used as a local treatment. So if you have a painful metastatic lesion in your hip, for instance, we can treat that with radiation, and it usually helps to control the pain, but it's not going to cure the melanoma you have in, say, your lungs or your liver. It's only going to affect the area that's radiated in the hip. Same thing with surgery. Excuse me. Surgery is more local as well. So if there's a spot in on skin or in one of the organs, and you remove that, it's only going to cure that particular spot. It's not going to help anything else in the rest of the body. And then if we have to do systemic treatment, we can do chemotherapy, immunotherapy, hormone therapy, or targeted therapy. And just to give you a little more information about all of those, chemotherapy is a cytotoxic drug. That means it's a cell killer. They kill cells, that's all they do. They do target certain phases of growth of those cells, but for the most part, they kind of are very indiscriminate and they kill everything. Immunotherapy is, these are actually kind of the big thing in oncology right now. These are drugs that will stimulate the immune system to do what it's supposed to do. The immune system is responsible for fighting diseases and killing things in your body that are abnormal, like cancer cells. So we use these medications to stimulate the natural immune response in the body to go out and find those cancer cells, tag them, kill them, get rid of them. These are very, very good in melanoma. Chemotherapy, not so great in melanoma, it just doesn't work very well. Immunotherapy is kind of our #1 treatment right now for people with melanoma. Hormone therapy is using hormones to treat cancer, does not work in melanoma at all, so we don't use any hormone therapy. Targeted therapy is something we do use in melanoma pretty frequently as well. These are generally medicines that are pills instead of IV infusion, and they are targeting broken proteins basically in the melanoma tumor itself. And so we can test a tumor, see which proteins are broken, And then we can use these targeted therapies to target those broken proteins and block them basically. And that way it allows the tumor cells to die, but it also prevents new tumor cells from growing. So that's very exciting and promising in melanoma as well. And actually what we're doing now is combining those targeted therapies with immunotherapies, and they've become very, very impactful and improved outcomes for patients. So just looking at a lymph node. So this is normal lymph node tissue here under a slide. And then what I wanted to show you is this is, again, a lymph node. It's a different stain, so it looks a little different. But there's this very tiny deposit here. And this picture shows a little bit more close up. So this is a deposit of melanoma in a lymph node. Seeing this very, very tiny, looks like maybe 20, 30 cells there, that upstages a patient from a stage 1 or 2 up to a stage 3. This will require systemic treatment for a patient. This is a lymph node that doesn't have that microscopic, but it's more macroscopic or gross involvement. And so you can see the melanoma is actually black in the lymph node. And surgeons report this all the time, that when they are resecting tumors from lymph nodes or from other organs, there is that black pigment that's present wherever it is. Not always, but most of the time. These are some scans. So I'll just kind of go through these quickly. So these are stage 4 patients, and this is before they started treatment. This is a PET CT scan. This is after they started treatment. And so you can see a big difference here. PET CT scans are the type of scan they use a radiation, a sugar that's marked with, a radiation that's marked with sugar, or it has sugar attached to it. And so any cell in the body that uses a lot of sugar will take that radiation up. It's a kind of a marked radiation, and so we can see it. So the brain uses a lot of sugar, and so that always is a really dark spot. But then the bladder down here, you urinate that radiated sugar out, and so the bladder collects it as well. Sometimes you can see the heart. It's not here as much, but usually the heart's using a lot of sugar too. This, you can see lots and lots of melanoma deposited in the liver, different organs, maybe the spine there, all over the body. And then only 2 weeks after treatment, you can see a huge improvement for this patient. This patient is definitely feeling a lot better after treatment. And I got a few more of these pictures for you. So same scenario, this is before treatment and another PET scan, and this is after treatment. And so you can see this skeleton, basically, these are bone mets all over this patient's body. After treatment, a huge improvement here. Still some there, but huge improvement. And this is a CT scan, so that's really just a fancy X-ray. And what they do is the patient is lying down, so this is their back and this is their chest, and their head is basically pointing into the computer, and their feet are coming out at you. So that's what we're looking at. And then they slice them up like a loaf of bread. This is a slice right through the lungs. And so you can see these little round spots here, some of these spots. These are all melanoma in the lungs. Okay, this is the heart, that's normal. Some of the blood vessels coming off the heart. And then this is 6 weeks after they started treatment. So you can see a lot of these big spots are almost completely gone. If not, they are completely gone. You can't really see any of them here. So you can kind of compare how they're doing on treatment. Obviously doing really well in responding to treatment. And this is one of the liver. And so this is a liver pre-treatment. There's a few little dark spots in here as well. This is a CT again, so sliced like a loaf of bread. And then this is what the liver metastases look like. And then on treatment and responding, you start to see them get smaller and smaller. And then at 36 weeks, things look a lot better. So great response here. And this picture is, again, those in transit metastases. So you can see in this patient, a lot of bumps and kind of pinky purple lesions, but then over time, things are starting to smooth out and get a little bit flatter. This nodule up here looks like it's starting to kind of recede a little bit. This one almost looks like it's almost entirely gone. So doing really well with the treatment here. And then there's a few more here. So you can see these superficial cutaneous lesions that we call them. And then over here, a lot of them are gone. There's still some there, but a lot better. So obviously we don't want anyone to get to that point. So the prevention is key. And some of the things around prevention: do a full body monthly self skin exam. Make sure you're looking at your scalp, your ears, your feet, your genital area. You should be looking everywhere. If you notice something, if you have a suspicious lesion, go see a dermatologist, have them look at it and get their professional opinion. They probably are going to have to biopsy something if it's been changing over time. And I'll show you what that looks like too. Use sun protection. Please use sun protection. At least 30. 30 is actually the best. You can use 60, 100, whatever you have. But the problem with that is you don't really get your bang for your buck. So they're more expensive, but they don't actually give you, like if it's 30 compared to 60, you're not getting double the protection. It actually kind of levels out. And so you're getting maybe like a 5% improvement in protection. So really 30 is ideal. Less than that, not good enough. So 30 is the best. Use your UV protective clothing and stay in the shade as much as you can. No sunburns, that's the bottom line, and no tanning beds. It's just too damaging to the skin. Oops, sorry, what's happening here? Here we go. So just a little comic break, and I'm going to show you how to be looking at your melanomas. So things that we pay attention to, A, B, C, D, E's of melanoma. A is asymmetric, B is border, C is looking at color, D diameter, and E is evolution. What does that look like? So here is A for asymmetry. If you can draw a line through a lesion and it looks basically the same on one side as the other, that is a good lesion. This is not going to be good. This has a lot of asymmetry around there. And then looking at the border. If it's a real nice smooth border, it's probably okay. If it has an irregular border, that would be something that you would want to have a dermatologist take a look at. Look at the color. If it's very uniform, there's not any differences in the color, probably okay. If you start to see shading, shadows, sometimes you see white spots or black spots in them, those should be looked at. That variegated color would be very important. The diameter, if it's greater than 6 millimeters, that's the size of a pencil eraser. If it's larger than that, you would want somebody to take a look at that. It's not to say that all of those larger than 6 millimeters are abnormal, but it's probably worth having someone look at it anyway, especially if it has some of those other characteristics as well. And then E for evolution. So is that lesion changing over time? Color, shape, size is changing over time. If you look at all your other moles and spots on your body, does this look different? It's something called the ugly duckling. So if you have one that stands out in particular, that would be the one that you want to have someone take a look at. Hopefully that makes sense. So there are a number of campaigns out there. This is from the Melanoma Research Foundation. They have this Get Naked campaign, and this young woman is Dayanara Torres. She was Miss Universe for 2019. She's from Puerto Rico, and she's a melanoma survivor. She was diagnosed with stage 3 melanoma. She did treatment, and so obviously she's a great spokesperson for protecting your skin. She's experienced it. She knows what it's like firsthand. And so the Melanoma Research Foundation does a lot of really good work. And this year they're using her as their sponsor or their speaker. And she's been doing a lot of national speaking. And I don't know if you guys are too young for this group, but this group did not practice sun safety at all. They did a lot of tanning. This is the Jersey Shore people, if you're not familiar. Snooki in the middle there. And even Snooki admits that she did a little bit too much tanning and has promised to at least switch to spray tans, which sounds better. So she is, and all the group are actually doing a lot better with their tanning. And then I threw a couple other groups in here too that you guys probably know. So this group here doing well with their skin care. They look like they're not tanning, and I'm proud of them. And then this group as well, doing really well with their skincare. They look like they're not over tanning either. So that looks fantastic. Now, that's not to say that we want you to do this. You don't have to look like this when you're outside, but please do just make sure that you're paying attention to the exposure. And if you notice you're getting a little red or tanning, then that's your body. It's telling you you're having too much exposure. So you need to protect your skin. if you guys are interested in looking at some really good reputable sites out there, this is a list of good websites so you can learn more about melanoma. You can learn about other cancers on some of these as well. So take a look at those. You gotta be real careful what you're looking at online because you never know if if they have good science behind them. And these are obviously very reputable websites. So I would feel comfortable with you looking at those. And then that is the end of my presentation. So if there are any questions, please do reach out and let me know. I'm happy to answer any questions at any time. Thank you.
Great job. Yeah, I will I have a spot in the videos where they can text me or type in a question and I can email it to you, and then I can post your responses for sure. But great job on that recording.